Okay, thank you, Dr. Darby. So I have a couple of the 3D printed models to show you first, and the two cardiac specimens. So these four are all different hearts. So the lab classification, subaortic, subpulmonary, and the doubly committed, and the remote VSD. The left upper here is that open the right ventricle. I don't want to talk about the atrium, just I will focus on right ventricular aspect of the ventricular septum. So open the right ventricle. You have your aorta and pulmonary trunk apparently going together from the right ventricle. Okay. So this is the outward septum. Definition of outward septum is the muscle dividing subaortic and subpulmonary outflow tract. And then you do have VSD, and almost all case DORV needs VSD. And here, if you look at the outward septum is fused to the left margin of the VSD, making this the outlet VSD exclusively committed to the aortic valve, and pulmonary valve is the away from the VSD. So this is a typical DORB with subaortic VSD and the subpulmonary outflow tract obstruction and small pulmonary valve. Okay. You can have this subpulmonary outflow tract, the wide, unobstructed, and then you call that type of DORV as the VSD type. If you have obstruction like this, it is similar to tetralogy of Fallot, except for in this case, there is the ventricular infundibular fold between the pulmonary valve and tricuspid valve below, which means that in typical tetralogy of Fallot, you have the pulmonary valve in fibrous continuity with the tricuspid valve. So here you have your double bilateral infundibulum. Okay, that is a little bit different from typical TOF, but surgeons wants to call this TOF type of DORV. So that is the left type 1 DORV with subaortic VSD. In contrast to that, this the one, exactly the same orientation, tricuspid valve, aortic valve, and pulmonary valve open. You can see that the VSD is very, very high. So this is the trabecular septum marginalis bifurcating into anterior and posterior limb. And then VSD is cradled to there. But in contrast to the other heart I showed you, outward septum goes to the other side of the VSD, which means that this outward septum between narrow subaortic and wide subpulmonary outflow tract, this outward septum goes to the right margin of the VSD, making this VSD exclusively below the pulmonary valve and is away from the aortic valve. Because this is theoretically deviated leftward, rightward, forward, and then you usually have a small subaortic outflow tract. And pulmonary valve almost always smaller than the pulmonary valve. And then because of this, you can have your aortic arch obstruction. In this case, there is the interrupted aortic arch. So this is a typical Tau-C Bing malformation or left classification DORV with subpulmonary VSD. Okay. Here on the left lower, you have a similar the orientation, exactly the same. You have opened the right ventricle. Again, this VSD is cradled between anterior and posterior limbs of trabecular septum marginalis. And then this VSD, over here, there is a very small the infundibular septum, outward septum, but VSD is across that. Therefore, VSD is below the pulmonary valve and below the aortic valve. That is why it is called doubly committed VSD. Okay, so there is a third type of DORV. The last one here is that you can see that the VSD is quite low. So here, can you see that small protrusion here? There's a medial papillary muscle of Lancisi, and then anterior leaflet and tricuspid, the septal leaflet porta tendinae goes to there. So this is the location of VSD. Surgeon, Dr. Lee will going to see the VSD in this way during the operation. And then if Dr. Lee finds that the muscle of Lancis here, and then VXD extends toward his right-hand side, that means that VSD is extending toward the inlet. And if it is toward the left side, this is a little bit toward the outlet, which means that this VSD has both inlet and outlet extension. And then this VSD, if you look at it, different from other VSD, this is the aortic valve and pulmonary valve is above here. So you can see aortic valve and tricuspid valve, there is a wide gap. So this is so-called right VIF, ventricular infundibular fold. Because it is very prominent, subaortic outflow tract is long, and then this VSD is significantly away from the aortic valve. Okay? And then outlet septum does not go to the right or left marginal VSD, but it is rather free-floating in the outflow tract. And then this is a pulmonary outflow tract. So this deserves the name remote VSD because this VSD is away from aortic valve, away from the pulmonary valve. However, if Dr. Lee takes this medial papillary muscle Lancis out and then close make the intraventricular baffling using lower margin of ventricular septal crest, and then along here, VIF, anterior margin of aortic valve, and outlet septum goes to here, and then you're going to have left ventricle to aortic baffling. And then after baffle is placed, and then you can put the medial papillary muscle Lancis on the baffle. Okay, that's how you're going to be able to make the biventricular repair. That's why I suggested, even if you call this remote VSD, you always describe whether it is a baffle over to the aortic valve or baffle over to the pulmonary valve, or cannot be baffled to either side. In this, if you do the baffle to the aorta, you do the arterial switch operation to complete the surgery. So these are the very, very classic 4 different types of left classification, but I will show you a little bit more of the cases. So, thank you. So here, we talked about the doubly committed VSD. So let me take this out and then show these two. Okay. So what it is that here below, you will see that the aortic valve and pulmonary valve in fibrous continuity, right? And then VSD is here. It is close to the aortic valve. It is away from the pulmonary valve. There is absence of infundibular septum, but however, this VSD deserves the name subaortic VSD. However, the case I showed you, there is a small remnants of outlet septum, but it is doubly committed VSD. That's why I said that the first day, presence or absence of outlet septum, there is some relationship between doubly committed, not necessarily. Okay? Absence of outlet septum does not necessarily mean that it's doubly committed. Okay? So that is one. And then one more here. So this is actually a more common form of tau-saving malformation. What it is that in contrast to the case I showed you here, remember that the outlet septum goes to the right marginal VSD, making this VSD exclusively below the pulmonary valve. Here in this case, the outlet septum does not go to the margin of the VSD. It is just anterior to the VSD. What it means is that aorta and pulmonary trunk, in the presence of complete TGA, moved forward and then making outlet septum free floating in the outflow tract. Behind the outlet septum, you have a pulmonary valve in here. And anterior to that, you have aorta. I find that in the clinical context, this is a more common form of subpulmonary VSD. If you have that one, externally, aorta and pulmonary artery are more anterior-posteriorly related. If we have this type of subpulmonary VSD, great arteries become more side by side. Okay? So that is it. And then lastly, in the specimen, okay, not last. So do I have 5 minutes more?
Yes.
Okay, so this is interesting, the DORV, open the right ventricle. Certainly, there is the aortic outflow tract. This is a pulmonary outflow tract here. And then you have outlet septum here. You see that the subpulmonary outflow tract obstruction, and then VSD is large here, and then you can see that the mitral valve, tricuspid valve, and mitral valve has the caudal attachment to the medial papillary muscle, actually right side of the ventricular septum. So this is so-called Tau-C being malformation with the mitral valve straddling. But I'm telling you, if you look at this VSD and this VSD here, that VSD is not even comparable. Okay, so that's why having DORV with the subpulmonary VSD does not mean that it is the same pathology with Tau-C being malformation. So I will tell you the double outlet right ventricle with mitral valve straddling, usually pulmonary valve is closer to that VSD, but VSD is not on the outlet septum. It is entirely going to the crux caudus and very, very large. It is more toward the inlet rather than outlet. Okay. So lastly, so I'll show you this. So this is the simulation of, already that I showed you very similar pathologies. This is tricuspid valve annulus, this is septum, so this is the aortic outflow tract, this is the pulmonary outflow tract, you have outlet septum, VSD again is quite remote, and then you have medial papillary muscle overlenses here protruding. If you have this one, your surgical outcome will be like this. So you have the graphically designed patch applied to the specimen, and this will be the LV2 aortic, a sort of intraventricular baffling. Okay, so then that the shape of the patch will be like this shape. Okay, and then we graphically, mathematically flatten it. And then they make the kind of plastic template for the surgeon to trim the patch on that one. And then that we find that finally, the colleague senior surgeon, David Barron, agrees that that is very, very helpful. So in short axis view, exactly the same. So here's the open right ventricle. This is left ventricle, tricuspid valve. This is aortic outflow. This is pulmonary outflow tract. This is outlet septum. VSD is here. And what you do is that patch will be applied this way. And then this is the outcome of surgery. Okay? So, and then you're going to have left ventricle to aorta. Even if the VSD is remote, you can absolutely do the intraventricular baffling after removal of this outlet septum a little bit. Okay, so then question is that I would suggest that the posterior wall should be native tissue so that this outflow tract will not be stenotic and during growth. Okay. So this is the simulation of the surgical outcome. This is mitral valve. This is the left ventricle. This is the right ventricle. This is that baffling leading to left ventricle to aorta. And then if you look at this, if there is room to shave out ventricular infundibulary fold a little bit, your outflow tract will be much, much less obstructed. Do you have 2 minutes or?
Yes,
yeah,
exactly 2 minutes.
Okay. So I will show you that here two specimens. Okay, so we used to have a very good specimen in the Shi-Joon hospital, but I find that with time there is significant deterioration of the quality of the motors. Okay, so here in this case, I will show you that only the right ventricular inside. So here, this is open the right ventricle. So this is a septal surface. This is a free wall, and then you have your tricuspid valve. So you can see that this is the anterior leaflet of the tricuspid valve. This is a posterior leaflet of tricuspid valve. This is the anterior papillary muscle of tricuspid valve, and you have the septal leaflet of tricuspid valve here. The reason why I'm showing you is that you can see trabecular septum marginalis body, anterior and posterior limb, and then VSD is cradled between anterior and posterior limb, typical outlet VSD below the pulmonary valve, right? But this is the aortic outflow tract. Therefore, this is rather chunky outlet septum here, right? Dividing the actually very similar to the 3D printed model, subaortic and subpulmonary outflow tract, isolating aortic outflow tract from the VSD, and then there is a significant subaortic outflow tract obstruction here. Okay, so here what needs to be emphasized is look at the tricuspid valve. So this is a septal leaflet, this is the anterior leaflet, and then actually these leaflets go to posterior margin of the outlet septum. So, and then if you want to shape this one too much, you can compromise the tricuspid valve function. So in echocardiography, so most important thing in this situation is not infrequent. So this the coda tendinae from the septal and anterior leaflet can be attached to inferior surface of the infundibular septum. That is the pretty tricky surgical situation. Okay, so that is another Tausig malformation having some issues of tendon apparatus. So the final case is another DORV, but it is a very atypical DORV. This is open right ventricle. You can see that here the tricuspid valve leaflet here, an anterior leaflet, and then septal leaflet. So this is the VSD. VSD extends all the way down here to posterior, and then outflow tract of right ventricle is large. This is a subaortic outflow tract. There is a very, very tiny subpulmonary outflow tract here. So DORV with severe subpulmonary outflow tract obstruction. But however, if you look at the septal leaflet of tricuspid valve, and this is the left ventricle side, actually that posterior part of septal leaflet goes to the left ventricle side. Is rather freeward side. What is this location is, in fact, is if you move this one back one, so just trust me, this is the orientation of the atrial septum. So this is the atrioventricular groove. Atrial septum goes to the AV groove, which means that this is crux cordis. Okay, and then your septum is here. So you can see that the ventricular septum is away from the crux cordis toward the right ventricle, allowing tricuspid valve straddling into the left ventricle. Although it appears that this is the left ventricular freewall, it is true that tricuspid valve goes there. Externally, that is the point where crux cordis is. Okay, so this is a typical tricuspid valve straddling, how the straddles across the septum. As I mentioned in my talk in the base of the ventricles, tricuspid valve straddling anteriorly is okay. Whole septum moves clockwise away from the crux cordis, allowing posterior part of the tricuspid valve straddling and overriding. Thank you very much.
Thank you.